everyone, and welcome to today's scientific webinar on the evolving management of valvular heart disease with a special focus on transcatheter therapies for aortic stenosis and mitral regurgitation. Over the past decade, structural heart interventions have transformed cardiovascular practice. However, before discussing therapies, it is important to understand the disease itself, why patients continue to present late, how our understanding has evolved, and what opportunities exist to improve patient outcomes. I'm delighted to be joined by an esteemed panel of experts who bring extensive experience in structural heart interventions. Let me introduce them all. We have with us today Dr. Ajit Mulasari, Chairman and Head of the Department of Cardiology at the Madras Medical Mission Hospital. Welcome, Doctor.
Hello.
We also have Dr. Sengot Velu, Interventional Cardiologist and Clinical Head of the Structural Heart Disease Program at Apollo Hospitals Group, India. Thank you for joining us today, Doctor. Next, we have Dr. Anantaraman, Senior Consultant Interventional Cardiologist and Clinical Head of Advanced Heart Failure, Cardiomyopathy and Transplantation. Welcome, Doctor.
Good evening.
We also have with us Dr. Ajit Pillai, Professor and Head of the Department of Cardiology at Kaveri Hospital, Radial Role. Welcome, Doctor. And finally, Dr. Nagendra Bhupati, Professor of Cardiology and Senior Interventional Cardiologist, leading the Structural Heart Disease Interventions Program at Sri Ramachandra Medical Center. Thank you for joining us, Doctor.
Yeah.
To set the context for our discussion, I would like to begin with the bigger picture. Dr. Mulasari, despite remarkable advances in cardiovascular medicine, valvular heart disease continues to be an important cause of morbidity and mortality worldwide. From your perspective, what are the major factors contributing to this growing burden?
Thank you for that question. Both in India and everywhere else in the world, the two types of causes for these valvular problems. One is, in India especially, is rheumatic burnt out disease, which presents with valvular heart disease early in life and could present with multiple sort of issues in the future life in terms of valve replacements and valve regurgitations. The second biggest cause, which is worldwide the number one cause, is degenerative disease. When I mean degenerative, it's age-related issues. As you grow older, just like you get gray hair and cataract, the valves, especially the aortic valve, will degenerate and will create something called as aortic stenosis, which is basically the valve getting small and impinging the flow of blood through that valve. So worldwide, the commonest causes are aortic stenosis because of degenerative valves and valvular regurgitation, either because of dilated cardiomyopathy, which basically means a heart muscle being weak, and secondary mitral regurgitation, and also degenerative diseases of the mitral valve, like a mitral valve prolapse. In India, still, I think rheumatic heart disease leads. There's also a condition called as bicuspid aortic valve, where the aortic valve has two leaflets instead of three, which degenerates faster and presents to us. So I think these are the predominant causes of aortic valve disease, both in India and abroad.
Dr. Sengot Velu, would you agree, or do you think the greater challenge is not the increasing prevalence, but the fact that many patients remain undiagnosed?
Yes, absolutely. Considering the population, the aging population, the incidence is quite high. As a patient ages, even in 70s, 80s, 3 to 4% of patients can have undetected aortic stenosis and even degenerative mitral regurgitation. So most of the patients, the restricted activity, they deny symptoms, and sometimes even they don't realize they are symptomatic because without their knowledge, they start restricting their physical activity. Even they have breathing difficulty. When they do more exertion, they reduce their activity. And basically, they don't understand that they have a problem. And some of the things they think it is related to aging. And that is another problem. And sometimes even they come to the hospital, they say their symptoms are not really significant. And finding it out is really difficult. So this is a real challenge. And you have to go for large-scale screening, or at least when the age above 50 or 60. And even later on, they should have routine screening. And until then, it is difficult to identify this population. Even sometimes a routine a general practitioner visit with just with auscultate and find a mama can make them, to understand the disease is there and refer to higher center or even for echocardiography can increase, and we can find it out early. The other important thing is even increasing the awareness to general physicians, because not even them, they have to be educated on the importance of diagnosing these valve disease early, so that they can be identified and referred for appropriate care.
One observation we often hear is that patients reach specialists much later than they ideally should. Dr. Anantharaman, why do you think severe valvular heart disease continues to be diagnosed relatively late, despite advances in diagnostic imaging?
Thank you, Supriya. I think it's an important question, and Dr. Sangatwal has touched slightly on this as well. The patients kind of adapt. There is something called patient adaptability. Over a period of time, if they're walking like 30 minutes, they will slow down. Without complaining symptoms, they will adapt themselves. The heart also adapts. When the valve becomes narrow, there are certain changes that happens in the heart. The heart kind of thickens, and some pressures will increase. The left side upper chamber pressures increase. Eventually, when they get into the stage of where the heart is not pumping or where the right sided heart pressure increases, that's the time we are seeing most of these patients coming. And a couple of other reasons is obviously the COVID made most physicians as well as cardiologists stop listening to the heart. So we don't. That's a sort of sorry state, but that's what it is. That's the important thing Dr. Sangatwal mentioned as well. If you auscultate, you'll find a murmur, then you will trigger an echo, and then it'll be found early. But the last but not the least is people kind of misinterpret this severe aortic stenosis or severe valve problem as a lower risk problem. It is worse than cancer. People has to understand severe aortic stenosis is worse than cancer, but if you treat it, it's much better than any other heart problem. So they can live to their life expectancy, whatever they're supposed to live. So yes, we do see these patients kind of referred late or come late or for various reasons I mentioned above. So things have to change. Awareness has to be there, and that's why programs like this is important.
When evaluating patients with suspected valvular heart disease, Dr. Ajit Pillai, what clinical features should immediately raise concern and prompt further investigation?
Actually, valvular heart disease symptoms are quite mysterious in the sense that it just like presents like vague tiredness, fatigue, to a very overt symptom like syncope, sudden loss of consciousness, and to even worse, it can be a sudden cardiac death or arrest. So the symptoms cannot be very typified, especially in the case of aortic stenosis. The symptoms are usually actually are picked up incidentally for a vague fatigue or breathlessness, which is very common in the elderly group. As it goes with heart failure with preserved ejection fraction, aortic stenosis causes increased LV filling pressures and heart failure symptoms. So we see patients with very various symptoms. If you ask me to teach a fellow what is the symptoms of aortic stenosis, we always say it is chest pain, which is angina pectoris, breathlessness, and syncope. But we hardly get to see this kind of classical triad of symptoms in patients. So anybody who is elderly or even otherwise presents with an undue fatigue, especially with on and off breathlessness, in which there is no obvious EKG finding, obviously the next step would be do an echocardiography and to find out having a low threshold for diagnosing aortic stenosis, especially if someone is above 60.
Dr. Nagendra, among all valvular heart diseases, severe aortic stenosis and mitral regurgitation receive considerable clinical attention. Could you briefly explain us why these two conditions are particularly important?
Thank you, Supriya, for this question. The impact of any disease on human life depends on how prevalent that is in the human population and what exactly it causes to their life. Mitral regurgitation is the most common valvular heart disease across the world. Aortic stenosis is the second one. So both the diseases cumulatively have a significant impact on patient survival and their quality of life. Number one. Number two, the disease severity, as mentioned by Dr. Anantharaman sir, some of the cancers have got a better prognosis as compared to aortic stenosis if it is left untreated. The third point is that these diseases have got a critical time point at which they need to be intervened. If they are not going to be intervened at the particular point, they have a significant impact on patients' survival and patients' organ. Sometimes it leads to significant number of hospitalization. The patient's breathing problem may go higher. They may develop into a state called as pulmonary edema. And it may also lead to irreversible damage of their heart, especially the left ventricle, left atrium, or the lungs, or the right side ventricle also. So these, before the particular patient enters into this phase of irreversible damage, it is prudent from physician point of view to identify such patients and treat them. If you're able to treat them at appropriate time, then they may lead to have a near normal life.
Well, that brings us to a very important aspect of management and timing. Dr. Mulasari, according to you, why has determining the right time for intervention become one of the most important decisions in valvular heart disease?
So the decision to intervene, that means either surgery or intervention, is based on two issues. The severity of the valve disease, which means that things have to be severe to be treated. And second is the patient's symptoms. So if the patient has got significant symptoms and severe valvular problems, that's the correct time to deal with the patient, because patients may live with a bicuspid valve or a mitral regurgitation for years without having symptoms, though the leak is significant or the valve stenosis is moderately severe, and you may not have to intervene with them immediately. Remember, whatever you intervene, whether it is interventions or surgery, many of them will last maybe 8 to 10 years, because these valves are tissue valves in terms of transcatheter treatment, and they usually degenerate after 10 years. So we do not want to keep on doing things in patients. So it's better to intervene when they are significantly symptomatic and the lesions are severe.
We have discussed why timely diagnosis is so important. Once severe valvular heart disease has been identified, Dr. Senguttavelu, what are the key factors that influence treatment decisions today? And has the decision-making process become more complex than it was a decade ago?
I think when the patient comes with some symptoms, or even when they're asymptomatic and they are diagnosed with either of the mitral regurgitation, or we have to put the whole patient perspective into consideration. It's not just the valve, but the whole patient. So what are his symptoms? How frequent and how is it really limiting and how severe is this condition? Whether it needs to be treated immediately, or can we manage with medication? Because not all these needs immediate surgery or treatment. Sometimes they can be in the earlier stage, which just needs a follow-up. So evaluation is very important to know the severity at which they have presented. And then if they find they're very severe and needs kind of treatment for the valve, then we decide, we talk to the surgeons, we have a heart team, and we decide which is the best appropriate treatment. Most of the time, what is best for the patient. Today, treatment is more individualized, and for the patient, it is not a generalized decision. So based on this patient's age, we talk about lifetime management, which means how many years this patient is going to live, and how long his valve is going to last. Whether the patient is going to live longer than the valve, then whether he needs more than one procedure in his lifetime. So all that is decided. That is why we always have younger patients. We generally consider surgery as a first option. And in elderly or patients with above 65 years, we consider this minimally invasive procedure, or transcatheter aortic valve replacement, or transcatheter Edge-to-Edge Repair. So age is one of the factors, and also we also consider the risk of surgery. Even in a slightly younger patient, if the patient is considered unfit for surgery or extreme high risk for surgery, then these patients are possibly candidates for minimally invasive procedure. So other thing is also patient preference is also taken into account, but it's important for doctors and physicians to emphasize which is the right treatment for that particular patient, and then we take a combined decision, right, with the patient's family as well as with the surgeon and ourselves to give the best outcome for that particular patient, not just for the immediate treatment, but over his lifetime.
Historically, surgical valve replacement or repair has been considered the gold standard for many patients with severe valve disease. Dr. Anantharaman, which are all the patients who can benefit better with transcatheter therapies, and what is the success rate of second surgery of previously patients who underwent surgery?
Right, Supriya. Probably I'll take this in two parts. The first part in terms of which patients will benefit from transcatheter versus surgery. There are two different pathologies we are discussing. There is a transcatheter aortic valve replacement as well as a transcatheter edge-to-edge repair. So the transcatheter aortic valve replacement, there are good standardized international guidelines on the recommendations of who should be considered for transcatheter. More than 75 age as a cutoff, and some of the guidelines more than 65. So in India, we have to sort of prioritize based on the patient's age, like Dr. Sengutwal said. More than 75 definitely is a candidate for transcatheter. More than 65 based on the other sort of issues, whether they have stroke, renal failure, other issues. Less than 65, considering for a transcatheter aortic valve replacement, there should be a good compelling reason to do it, like a liver failure or other sort of major issue. Now, coming back to the other kind of aspects is, as Dr. Sangdwell said, is a lifetime management. If the patient has got other issues like cancers, where the life expectancy is reduced, where one valve is going to outlast, where there is bleeding issues, where they cannot take blood thinners, then definitely transcatheter is the option. With regard to this edge-to-edge repair for the mitral, again, the surgery is the first and preferred option at this point in time. But the patients who cannot have surgery or are at high risk of surgery due to various reasons, they are the ones who will benefit. Or there are certain group of patients who can be made candidates for surgeries or transplant with this therapy. They will be coming in a very late stage to us, like liver failure, kidney failure. We can do this edge-to-edge repair and make them candidates for that. With regard to your question about the redo surgery and the outcomes, redo surgeries, one of the issues is you still go through the same sort of breastbone. You have to cut through that. So there will be already additions from the previous surgery. So this increases the surgical time. Now, the second thing is, so with regard to the redo surgery, obviously we go through the same scar, open the chest, so there will be additions, there will be bleeding risk. And also the second time heart-lung sort of bypass carries a additional risk. And more than this, the stroke risk, all the other things are much higher. So if you put it into perspective, if it is a single valve redo surgery, it's about 5%. If it's a double valve, it will be much higher than that. But with regard to the valve-in-valve procedures, like the aortic or mitral, both of them with the transcatheter, the risk is much lower. So it's probably less than sort of 1 to 2%. And it's similar to the first time procedure we are doing. And we have shown that in large registries, like the TB registry, the repeats. So definitely, somebody needs a redo surgery. It has to be discussed in a heart team, and has to be made, a decision has to be made based on the patient's rather than the preference. So we have to have a good heart team discussion, a surgeon, cardiologist, and the imaging specialist. So that's where it is at this point.
One of the most significant developments in cardiovascular medicine has been the emergence of structural heart interventions. From your perspective, Dr. Pillai, how do the therapy and access hospital infrastructure help the patient?
I think the first and foremost thing is actually evolution of the heart team, which was never in the picture before the transcatheter valve therapy came, and soon it has gone into the coronary spectrum as well. So that is one of the good things. I think the surgeon, the anesthetist, and the cardiologist start sitting together and discussing about a patient. I think that's the most important thing which has happened across all the centers which which has adopted the heart transcatheter valve therapy. I would say the adoption has been extremely good, even in a country like India, where the government doesn't fund these procedures, which are basically expensive because of the costly implants. The therapy acceptance has been extremely good, I would say. I think there are patients who and families who ask for minimally invasive therapy, just like robotic or laparoscopic procedures. I think today TAVI is just another procedure. Thanks to the knowledge we gained from training abroad, as well as proctors coming in from various parts of the world. Number two, the patients have been, since it has become more affordable, obviously there is more awareness and there are more centers. You see the TAVI procedures 5 years back, even in our country, the number of centers who have been doing these procedures has quadrupled or gone up to 5 or 6 times because the therapy has been more accessible because of the indigenous manufacturers.
Before we move into discussing specific therapies for aortic stenosis and mitral regurgitation, I would like to ask one broader question. Looking back over the past decade, Dr. Nagendra, what do you think has been the single biggest change in the field of structural heart disease?
If you ask any cardiologist, they would say the single most important invention in the field of intervention in cardiology is coronary angioplasty, which was performed by Professor Anders Gunsing in 1977. Similarly, any structural intervention is the single most important intervention is the first TAVR which was performed in France by Professor Alain Cribier in a very sick patient who had a leukemia who was declined surgery. Following the surgery, the patient survived for a few months. That changed the way how we treat such patients. If you look at the TAVR therapy, it didn't evolve just like that to a mature therapy. We started with the concept of TAVR was evolved in 1985 from Kribier's brain. Actually, it got into existence it nearly took 1.5 decades to come into real existence. Following which, gradually we studied patients who were denied surgery. That is called, we call it as inoperable patients. Following which, high surgical risk, intermediate surgical risk, and low surgical risk. From 2019, even in Western countries, there is no need to calculate STS score to suggest a patient TAVI if they are old enough to receive such therapy, or if they are if the survival is going to be less than 10 years, then its preferred form of therapy, the durability of the valve is going to be good. That means that the preferred form of such therapy. Other structural heart diseases like mitral regurgitation, pulmonary disease that happens especially after congenital valve surgeries, and tricuspid regurgitation followed the path what TAVR actually followed. Currently, the TAVR therapy and mitral therapy predominates the structural heart valve therapies across the world. However, the pace at which the tricuspid therapy is moving forward is phenomenal. So if you ask me, it is the TAVR therapy that paved the strong foundation for structural heart intervention therapy across the world.
Whenever new therapies emerge, patient selection becomes even more important. In your option, Dr. Mulasuri, who are all the ideal candidates for mitral clip therapy?
So mitral clip is a new therapy where the regurgitant valve, which is either due to degenerative valve disease or due to a secondary mitral regurgitation due to a cardiomyopathy, instead of a traditional surgery, which is a bit of a high risk, especially in patients with heart failure and a dilated heart, are now being treated by putting a clip. A clip is a sort of a stitch on the mitral valve through a tube, and that clips and holds the valve leaflets together and makes that valve, instead of a single valve, into a double valve and reduces the leak. This was traditionally done in surgery and it was called as Alfieri stitch, which has now been moved into a transcatheter therapy. The issue has been evolving all over the world, and now we have newer and newer ways of doing it, newer and newer types of clips being done, and things are getting easier and better in terms of ease of treatment.
Patient selection is often described as the foundation of successful structural heart intervention. Who are all the ideal candidates for TAVI therapy according to you, Dr. Sengatavela?
Thank you. I think when we started, we were one of the earliest to start TAVI about 11 years ago. We used to take high risk, extreme risk patients, elderly who have high surgical risk, and then we think instead of surgery they can consider this therapy without surgery using transcatheter methods. But today, with so much advances and the expertise and the techniques, and the TAVI has become a very simple procedure compared to surgery, and with so much of new evidence coming up, TAVI is now the number one option for patients with aortic stenosis, generally above the age of 65, I would say. But generally above 75, the most of the guidelines are clearly saying TAVI is the first option, provided they have severe aortic stenosis. And if the patients are between 65 and 75, of course, in India, we offer TAVI as a first option. But of course, we do consider surgery as well, and we have a good discussion with the patient as well as with if the patient is suitable for both, then we consider TAVI if the patient's wishes, and we usually talk to the patient and the family, and as per the wish, we decide. But if a patient has got a bad anatomy, even though they are younger, say 65, maybe surgery. But the anatomy means, which means when we find that the risk of TAVI may be slightly high if they have high amount of calcium, or because of their valve disease, which is bicuspid, which means the valve is being affected from birth, and that is causing heavy calcium. In a younger patient, we would prefer that the patient goes for surgery. Whereas a patient above 75 years, even the anatomy is risk, the surgical risk is going to be very high, and these patients will go for TAVI despite a little higher risk with TAVI. So basically, what I'm trying to tell you is the risk, the patient's risk, age, and the type of disease all is discussed. and the best option decided for that particular patient. It is not a general TAVI for all. It is specifically decided based on this individual patient's risk of TAVI, risk of surgery, and multiple other considerations. Like, for example, whether the patient has already had a stent, and this patient will probably, we have to think of which valve to put depending upon multiple factors. We decide this is the best option for the particular. Some of the patients, really young patients, they come and ask, even less than 50 years, they come to us and asking for TAVI. And we need to really convince them, telling them 50 years or 55 years, we should tell them that surgery is a better option for them, considering that in the future they might need another procedure, which TAVI will be the best option. So I think choosing on use individual patients' risks and symptoms, and then decide which is the best option, who is ideal candidate for that particular therapy.
Modern structural heart interventions rely heavily on imaging. In your experience, Dr. Anantraman, how has imaging changed procedural planning and clinical confidence?
This is an important, vital question, because when we started doing TAVIs more than 10 years ago, 10, 15 years ago, everything was based on echocardiogram, either transthoracic or transesophageal. So the assessments we were doing were not good enough. So we were having a lot of vascular issues. We were having issues with the leaks around the valves, and we were having valves kind of embolizing as well as stroke, all the other risks. Since we started using CT scan as the sort of main imaging modality for planning for the transcatheter aortic valve replacement, we were able to minimize these complications significantly. Now the vascular complications less than 1%, pacemakers are less than 5%. We don't see the paravalvular leaks at all, and embolizations are rare, and deaths are rare because of this CT. Now the future prediction models where we feed the CT and then put prediction models again sort of reduces the risk significantly. The other imaging modality we use quite routinely is something called transesophageal echocardiogram, which we use it for the Transcatheter Edge-to-Edge Repair procedure. Without a transesophageal echo or an intracardiac echocardiogram, it will be impossible to do this procedure safely and successfully. So the imaging part sort of plays a very crucial part. Now the future is that we will be able to fuse all these images, the CT scans, the transesophageal echoes, and whatever imaging modalities in the cath lab. So we can fuse it, and they can navigate. The echo navigation will help us to do the procedures even more safely. So we are almost nearer to like surgical like results. The surgeon opens and puts the valve. So we can do almost nearer to that results in this day and time with the transcatheter aortic valve replacement. I'm pretty sure we'll get to that with the other procedures as well fairly soon.
As experience has grown, clinicians are increasingly treating patients with more challenging anatomies. Dr. Pillai, what have been some of the biggest lessons learned while managing these complex cases?
Complex anatomies mean more challenges with respect to vascular access, with respect to navigating the valve, with respect to valve positioning, with respect to post-implant complications like paravalve leaks, valve stability, conduction disturbances, and so forth. But I think one thing which I like to mention here is that with TAV, as far as TAV is concerned, we have started off with more complex, more high risk, and more surgically inoperable cases than what we do now. So we are actually started doing more complex work to start with. Now we because of the imaging and because of the skill set, because of the learning curve which has been crossed, most of the leading centers do get good outcomes, at least predictable outcomes with respect to TAVI. With respect to the complications, these are predictable complications. So nowadays we don't kind of get complications which are unpredictable or unpredicted. Vascular access issues is a major complication, and with the advent of CT and with the advent of new deliverable systems which are more vascular friendly, the complications have come down, although it's not zero, but still it is predictable. With respect to the valve stability and the implant, the understanding of the anatomy with the advent of CT, that has also become more predictable. But yes, we are treating more complex cases. But then, as compared to somebody who is doing a coronary intervention, structural heart interventionalists are actually of about surgically inoperable cases or surgically declined candidates who were more older. An average tower age has come down definitely, not only abroad but also in India. And also with expertise, we are able to give optimal outcomes to these complex anatomies. So I think that would be my answer. We still have a substrate which is extremely challenging, but then that, as I said, with the help of surgical team, because it's a heart team decision, we would be able to offer hybrid procedures, whether it is vascular or alternative access. So yes, I think the more and more complex patients are getting treated, but with much more predictable complication scenarios.
One concept that is receiving increasing attention is lifetime management of patients with valvular heart disease. Dr. Nagendra, how has this influenced treatment planning in contemporary practice?
That's a very important question, Supriya. So the lifetime management is one of the important features that we consider when selecting the particular patient for any kind of procedure and selecting a device. If you look at the Indian government data that got published in 2022, an average Indian female who crosses 60 years are expected to be alive for 19 years, and an average Indian male is expected to be alive for 17 years. The reason why we say 65 years, it's not a magic number. It's all data driven. A surgical valve or presumably a TAVR valve is expected to be alive, functional, not alive, functional for 10 years average. So if you implant a valve, a transcatheter aortic valve at 60 years, the patient is going to be alive till 80 years. The patient may do a second surgery or second valve, transcatheter valve. The TAV in TAV, what we call it is putting a TAVR valve inside a TAVR valve may not be feasible in 25% of the time because of the anatomical issues that can happen in the particular procedure. So that time, a patient may go for surgery. So a surgical risk of an individual at 60 is much lower as compared to 70 years. So that is the important reason why we look at the longevity of the particular patient and durability of the valve. In addition, the anatomical factors like what is the ECG findings in the particular patient, how much exactly calcium is, what is the CAD status, as exactly told by Dr. Senguttuvel, sir. Will this particular patient needs a coronary intervention? All these factors need to be considered when we select a valve. So lifetime management include consideration of TAVR versus surgery and which valve should we appropriately select for the particular patient. This determines the particular patient's better quality of life. What is good for this particular patient or what is easy for this particular patient today should not impact his survival or should not impact the procedure what we undergo later 10 years down the line. So we have to presume that if he's going to be alive for 30 years or 25 years, how are we going to manage this particular patient? That is called as lifetime management.
As transcatheter therapies continue to evolve, clinicians are increasingly treating patients with more complex anatomy. Dr. Mulasri, what are some of the challenges that require particularly careful planning?
So the first thing is that you need to have a heart team. That means a cardiologist who knows to do this procedure, a surgeon who traditionally used to do the procedure, anesthetist, a person who does a good echocardiography, because many of these procedures are directed by a good echo. So it's like a heart team approach. You need to have a group of people in a hospital who are interested in this sort of a treatment, who are well trained, and who can do these treatments pretty safely. The second point is to get trained, because this is just evolving in India. It's also evolving all over the world. So you need to have proctored management of these patients for the first few cases, see people doing it, then get them to help you out to do it. And then once it becomes standardized, then you do it yourself and learn how to do it. So I think just like any other therapy, there is a learning curve in all this so that you avoid complications and don't, get into trouble with the patient.
Dr. Senguttuvel, the heart team has become central to structural heart care. Can you share an example of how multidisciplinary discussion has influenced a treatment decision in your practice?
The heart team is actually a team consisting of interventional cardiologists, cardiac surgeons, anesthesiologists, and even imaging, sometimes echocardiographers and others. But routinely for treatment decisions, we really don't have a practical heart team in our country, but we do consult the surgeon sometimes. But the heart team as such helps during procedures. We always work together. We have the anesthetists and surgeons also being with us in the room sometimes. So for an example, what one of the cases I can tell you, I remember, I think a 68-year-old man. He was actually one of the doctor's family. They were very keen to have TAVI. This patient had by birth he had only a two cusps in the aortic valve, and it degenerated very quickly. And this patient actually came to have the TAVI. And when we evaluated with the CT scan and multiple other tests, echo, we found that the valve, the sinuses, which means near the valve, the sinuses are very narrow and the coronary heights are very low. And this patient had a high risk for coronary obstruction, which means high risk of heart attack during TAVI. And based on that, we discussed with the surgeon, and surgeons felt the surgical risk is very low. And considering that even though they are younger, sometimes the risks may differ. And as I already mentioned, this collaborative decision with the surgeon and cardiologist, we are able to arrive the best options of treatment for that particular patient. And we finally decided this patient will do well with surgery, and this patient did really well. They put a Resilia surgical valve, and the patient did really well. So it's important to consider each patient like that. That's the importance of heart team. And similarly, other way also it happens. Sometimes patients come for surgery and they find that surgeons find they have high risk because they have already pre-existing kidney disease or sometimes even a severe lung disease, and they ask us and we decide maybe TAVI is a better option. So that kind of a decision helps, combined decision helps to take the best options for the particular patient.
Dr. Anantharaman, structural heart interventions continue to evolve rapidly. What is the level of training programs required for the doctors and the availability of such training centers in India?
This is a fantastic question. I'll probably take it in two parts. That's one is the training requirements and what is available in India. Firstly, training requirements. We were fortunate because I was in UK for 20 years, so I got trained in cardiology intervention as well as structural.
Okay.
In terms of the training you get in India, the general cardiology and interventional training during your MDDM is not enough to practice as an individual operator for a structural transcatheter valve. So you need to have a dedicated fellowship, which is difficult for the cardiologists just completed DM to go and have a fellowship elsewhere. So what needs to be done specifically in India, because there are international guidelines obviously for each country on number of procedures, all those things. We do not have anything like that. That is first thing we need to formulate as a society, Cardiac Society of India, as well as the Structural Society, because we have India Valves and all our colleagues are part of it. So we'll probably need to draw a training requirement guidelines for the newcomers. The second thing is in terms of the training centers in India and training availabilities, it's random at the moment, but it can be better because now it's a mature therapy in India. It's more than 10 years in most of the centers. The volumes are good enough. So if 2 or 3 centers join, especially like in Chennai, we should be able to train 2 or 3 candidates in a year. So it just needs some integration and some support from the companies. The future is obviously we need integration, we need guidelines of our own, and we can train our next generation properly. So that's where we have to move in India.
We have spoken about where we are today. How can we achieve early identification of valvular heart disease patients, according to you, Dr. Pillai?
I think it is just something like coronary artery disease. Now we have well-established preventive master health health programs where we identify patients with coronary artery disease much early. In an urban center or even a semi-urban center, the so-called preventive health checkups are very rampant. And thankfully, most of these checks are involving an echocardiography, which is a fundamental tool in diagnosing valvular heart disease. So when we are talking about early identification of such valvular heart disease, I think it's already quite established in urban cities and even in government setups. I think governments, especially Tamil Nadu state government, I have seen announcing that preventive health checkups to be started in a district level hospital. So these are some of the important steps I would reckon. So it is something like coronary artery disease, what we witnessed 20-25 years back. Then we had only patients with ACS presenting as STEMI or NSTEMI, unstable angina those days. And then we had patients who presents with classical angina pectoris. But now we see patients who come with a positive master health, which shows either a treadmill which is positive or either a calcium score scan which is positive. So yes, why not? We an echo is part of your regular preventive health program, so you'll be able to identify patients at much earlier age. And then awareness of TAVR, as one of the speakers have pointed out, it's now well aware, and many of the communities are well aware, even outside the doctor population. So they know that actually there is a minimally invasive option. Like today, no one is. There are patients who specifically come and ask for laparoscopic cholecystectomy or laparoscopic hysterectomy or a robotic surgery. So I think the awareness are well and ahead thanks to the digital media, all these AA mediated kind of platforms where people get a lot of digital education. So thanks to the so-called preventive health checkups, I would say the future is very bright as far as valvular heart disease is concerned. Because overall cardiovascular, I would say among the specialties, the cardiovascular specialty is one which is got a very much more well established, robust preventive and early screening programs. Screening for valvular heart disease, especially aortic stenosis or for the mitral regurgitation, all for that, or even any of the structural heart disease is what we are discussing today, is an echo, a routine transthoracic echocardiography is more than enough, which makes a general physician or a preventive health medical officer to refer to a cardiologist. And with the growing infrastructure, both private as well as government, I would say I think the future is extremely, extremely bright in our country as far as treatment of aortic stenosis or mitral regurgitation is concerned. Thank you.
Artificial intelligence is increasingly being discussed across every area of healthcare today. Dr. Nagendra, how do you see AI contributing to structural heart interventions now and in future?
And there is a misconception about among kind of physicians that a certain set of specialities may wean off if AI is going to come up. Unfortunately, that's not the fact. AI is going to become a complementary tool for most of the physicians. It's not going to take our job. It's going to help us do the job better, especially in the field of interventional cardiology. Conventionally, aortic stenosis is diagnosed by means of symptom assessment, and when we put a stent, there will be a noise that is heard from the chest, and we confirm the diagnosis by means of echocardiogram. There could be some telltale evidence of enlargement of heart muscles in the ECG. Imagine that the same set of skills what I have in identifying the murmur, what we call, by putting the stethoscope on the chest wall, may not be there with the general practitioner who is there remotely from a city. So, in order to avoid this discrepancy, what AI is particularly doing is, say, a guided stethoscope is available now. It has been proven to be superior to the conventional stethoscope that has been shown to increase the diagnosis of aortic stenosis. You put a stethoscope on the chest wall, if there's going to be a murmur, the AI itself, algorithm itself will say, hey, this patient may have an aortic stenosis. Currently, the team from Mayo Clinic and Stanford are pushing forward to diagnose aortic stenosis from a baseline ECG itself, which is tremendous invention in the field of cardiology. Similarly, echocardiogram. We all do echocardiogram, but it may not be available for a patient who is remotely in a village or in a tier three kind of city. Quite often, aortic stenosis can be missed, especially if the gradient what we measure, that is the pressure difference across the ventricle and aorta, are not good enough to call it aortic stenosis. People label it as a moderate aortic stenosis and leave the patient. It needs certain level of skill sets which may not be available with everyone. So, however, if AI is there to identify the myocardial texture itself, it can identify aortic stenosis severe, it seems. So it's all coming up. There is a special software which is FDA approved now called by name EchoSolve, which is available to identify such diseases much earlier than human brain. So AI helps in diagnosing the problem much earlier. Number two, similarly, when we get a CT scan done, and if you give it to AI tool, by AI interpretation, we'll be able to identify, okay, this patient is going to receive the first valve. 10 years down the line, if this particular valve generated, then what exactly will happen to the patient if you put a second valve? What is the second valve should I put? Should I send the patient for surgery at that point of time? So AI helps phenomenally in managing the particular patient lifetime management, what we call is lifetime management. So with all this information, we are able to tell the patient to make a specific decision for their treatment of their illness, which we call it as shared decision making. that is involving patient in making a decision process in their treatment is called as shared decision making. In addition, the specific simulation software, we are also part of a particular simulation software program along with Georgia Institute of Technology by name Dasi Simulation. Professor Lakshman Lasi is the lead inventor of the particular program, where we are able to identify, okay, this patient, what is the risk that could be that could happen in the particular patient during the TAVR, during the first TAVR itself. We can identify catastrophic complications by simulating this patient. And the last but not the least, the future is going to be AI-based digital twins. So I will create a digital twin for the particular patient CT scan anatomy. I will put multiple valves. I will identify, okay, this valve gives the better hemodynamics for the particular patient with least amount of complications or side effects or adverse events that could happen with a particular procedure. And I will go with this particular valve. So AI is going to become an integral part of interventional cardiology, especially in the field of structural heart disease. We should start embrace it rather than compete with it.
As indications for TAVI and TEER continue to expand, Dr. Singutwil, what do you believe will be the single greatest challenge in ensuring durable long-term outcomes for patients?
That's a really good question. And I think you have put the right word, durable. I think that's very important. I think, unfortunately, the current valves, particularly what we are using, the tissue valves, do not last their lifetime. It lasts generally about 10 years, or even sometimes it works for a little longer. Another problem is these patients also need sometimes you need multiple drugs and clear follow-up, and we need a solution like a mechanical valve, which is usually done in young patients. They last a lifetime, but they have to be on anticoagulation. But the future, I think one thing which we are all dreaming is to get polymeric valves, and the polymer valves is the one which will be like a mechanical valve. It will last long, no need for any blood thinners. And that is a dream what we have, and already initial working investigations are going on. We still do not have the valve in clinical practice, but definitely that will be the future, and it appears very promising once we have these polymeric valves, which we can place it and leave it for lifetime.
While advances in structural heart therapy are exciting, Dr. Mulasri, what support can clinicians and patients expect from the government?
So there are two parts the government can do. One is the access for therapies into government hospitals for these patients, which means many of these patients, especially the lower socioeconomic bracket, cannot afford therapies into private hospitals. So you need these therapies to be available also in the government and quasi-governmental services. The second thing is to get the procedure at a lower cost, because no government can afford to do this to everybody. And so it has to be a correctly selected patient whom this treatment can be given, like TAVR or CLIP in a governmental hospital. And finally, the government should encourage Indian companies to make these devices so that the cost of these procedures and devices comes low, so that most patients or many patients can afford this treatment in this country. So I think multiple ways: access, affordability, enterprise in India, building up local abilities, and getting the procedure both better and cheaper to the patient.
Coming to the last question, Dr. Anantharaman, how does the insurance cover TAVI and TEER therapies now, and what is the ideal situation for the next decade?
This is very vital, because we talked about the technology, we talked about the evolution. End of the day, patients should be able to pay for this. Otherwise, they will not get these procedures done. There are sort of welcoming things in India. Obviously, affordability is increasing, and also the government support is increasing. So schemes like Ayushman Bharat, the central government scheme, the ECHS scheme, ESI, as well as the state government schemes, do support transcatheter aortic valve replacements. With regards to other procedures like the Transcatheter Edge-to-Edge Repair and other procedures, it has to come, but it's not at the moment. It's not recognized or approved by these schemes. The private insurance are very variable. Some of the insurance do cover fully depending on their eligibility. Some of them partially cover, some of them do not cover. So most of these patients end up paying out of the pockets. There's quite a lot of variability with this. It's not the same with the surgical aortic valve or surgical mitral or surgical treatment, because those things are very well covered and supported. And the reason for that is this is an evolving therapy. There's a lot of misconception by the insurance as well as by the physicians about this. So one of the other reasons is even though the US as well as UK cover these procedures extensively, in India, we do not have an outcome-based center recognition. That's what happens in UK or US. Firstly, you show an outcome-based center recognition to the insurance company, and they get fully reimbursed for any procedure. So subsequently, when the volumes increase in India, when the insurance companies recognize these are vital procedures, I'm pretty sure we will see outcome-based center recognitions in India where the total cost will be reimbursed. It's not far away. But at this point in time, yes, we need to work on that. We need to submit to the government. We need to get approvals done. And I'm pretty sure within the next 5 to 10 years, we will see all these procedures recognized by all schemes. Thank you.
With this, we come to an end. Thank you to all our distinguished faculty members for sharing your expertise and valuable perspectives. Today's discussion has highlighted that the management of valvular heart disease extends well beyond individual procedures. Success begins with early recognition, accurate diagnosis, multidisciplinary collaboration, and patient-centered decision-making. We have explored how structural heart therapies have expanded treatment possibilities, the importance of careful patient selection and procedural planning, and the exciting opportunities that lie ahead through continued research, innovation, and education. On behalf of the organizing committee, I would like to thank all our participants for joining us. We hope today's discussion has provided practical insights that you can apply in your own clinical practice and has stimulated further thought about the future of structural heart care. Thank you, and we look forward to welcoming you all again.